Welcome back to the EADV Podcast. In this episode, Dr. Sarah Walsh is joined by Dr. Max Oscherwitz, a physician with a joint MD and MBA background whose research focuses on the intersection of business and dermatology. Together, they explore how private equity is reshaping dermatology in the United States, from increased capital and reduced administrative burdens to concerns about patient access, consultation quality, and a growing emphasis on cosmetic care. But before we get into that,
discover the EADV's digital education offer, your getaway to flexible, high-quality learning. Access online courses led by experts, earn CME credits, and explore resources designed to help you grow your skills anytime, anywhere. Enroll now to start learning.
An engaging discussion for dermatologists and healthcare professionals interested in understanding how financial models influence clinical practice and how physicians can prepare to navigate these changes.
Hello and welcome to this edition of the EADV podcast. My name's Sarah Walsh. I'm a dermatologist and I'm speaking to you here from London. And today I'm absolutely delighted to be joined by a colleague all the way in Arizona, Dr. Max Oscherwitz, who recently contributed an article to the JEADV, which I found absolutely fascinating. And that's why I've invited him to speak to me today. So Max is a combined MD, MBA graduate from the University of Alabama Hersink School of Medicine. And he's currently completing his internal medicine training at Duke and will then progress to his dermatology residency training at the Johns Hopkins University. But really interestingly, when I was researching for today's podcast, I learned that Max, in fact, before medical school, served as a Fulbright scholar and spent a year living in Colombia, where he was teaching at one of the region's largest public universities. And alongside that was working with the Colombian Red Cross, setting up makeshift clinics for migrant Venezuelans fleeing from their home country, which is a really fascinating thing, which I'd like to discuss with you, Max, a little bit later. But from a dermatological point of view, Max is rapidly forging a niche in the area of the intersection between business and dermatology. And it was an article which he submitted to the journal about the use of private equity in dermatology that attracted my attention. But before we get onto that, Max, I wonder if you could explain to us a little. You're dual qualified with an MBA and a medical degree, which is a relatively rare phenomenon. What made you pursue the MBA?
Yeah, and Dr. Walsh, thank you so much for having me here today. Really, ever since I've been younger, I've been really interested in working in a team dynamic. Throughout high school and college, I often found myself working on many different types of teams in my studies. And during my time as a Fulbright scholar, I worked in the Colombian Red Cross in a team dynamic, and at the university that I taught at as well in a team dynamic. So I wanted to find a way to really refine my team leading and management skills. And for me, I wanted to also combine that with the intersection of medicine and business. So for me, it made perfect sense to jump into a joint MD, MBA. And I think it accomplished that. I'm very, very happy with the result.
Fantastic. It must have been a very busy few years combining those two disciplines, because I imagine an MBA is enormously demanding. And our listeners will all certainly know that a medical degree is very demanding. How did you manage to combine it all?
Yeah, absolutely. And it was a lot of work for sure, but I really enjoyed getting to meet my colleagues on the business side of things and then also on the medicine side in medical school. So it honestly was a nice break. And I think it really made me a more well-rounded and holistic person.
Yeah, I'm sure it did. Now, the reason you and I first came into contact is I was on the editorial team assigned to a manuscript that you submitted, looking at the impact of private equity funding on the quality of dermatological care. And to set the scene, I think it'd be quite useful if you explain to our listeners a little bit about what this means. What is private equity? Because this isn't really a model that we've seen very much in geographic Europe as yet. We're used to the model of kind of physician-owned and run clinics. And just, I guess, a little bit of history. When did the private equity model start to creep in stateside?
Yeah, absolutely. That's a perfect transition point. So private equity is really an umbrella term. It includes things like venture capital, if the listeners have heard of that before. And typically these conglomerates and groups are organized into different types of firms. This dates back to the post-war 1940s in the United States. And individual groups would actually combine capital, typically funds in the form of monetary funding of some sort, and they would invest in small businesses or different structures of companies. Typically, this was done with the overall goal of obtaining a return on investment. It's referred to private instead of public because the companies aren't publicly traded. So like I was saying before, it originated in the US in the mid-1940s, and ever since then, it's really evolved. And it first took a step into medicine in the mid-1990s, spreading into hospitals and nursing home primarily, before spreading into individual private practices later on. Little statistic here, according to the American Medical Association, in the end of 2024, almost 7% of US-based physicians characterized their practice as private equity or PE owned. And for us here in the United States, the most common PE owned specialties are dermatology is 1, ophthalmology is number 2, and gastroenterology is number 3.
Okay, so practices where there is a large kind of outpatient ambulatory commitment. And so, yeah, the history, so 30 years, so it's actually quite, it stretches back quite a way in the States. And just to help our understanding of it, can you give some reasons why somebody in a physician-owned practice, an established practice, might want to seek private equity involvement? So what are the potential benefits to the doctor, to the medical staff?
Absolutely. That's another great question, Dr. Walsh. So first and foremost is the ability to infuse a large amount of capital in a very rapid manner into the practice. So especially in dermatology, I think we're all aware that some of the greatest and latest technology isn't cheap. For instance, lasers can cost hundreds, if not more, of thousands of dollars. And so really just being able to infuse that capital in a fast and rapid manner can help and be very appealing to physicians. Can also help with opening new locations if somebody wants to franchise their practice, so to speak. And it can also allow people to organize and hire more staff. The second way that private equity can be appealing is that it eliminates a lot of the need for physicians to conduct administrative tasks. So here in the United States, it's not uncommon for physicians to really have a large role in things like negotiating or revenue cycle management, accounting, credentialing. So really taking that administrative burden off of the physician is something that private equity companies can do. And then the last thing is that here in the United States in particular, we have enhanced negotiation power with insurance companies and or hospitals that practices are sometimes aligned with. So that in turn can lead to higher physician salaries and can be another reason why it's appealing for physicians to partner with private equity firms.
Yeah. So I can relate to that in the sense that I think doctors may or may not be natural administrators, bookkeepers, entrepreneurs, and it may be a relief to sort of relinquish some of that burden. But I guess, you know, your article very nicely drew out the fact that the goals of the medical staff and that of the private equity firm may not necessarily be aligned. And that's, I guess, where some conflict can arise, some mismatch. And you presented very nicely some of the research that's been done in this area. Could you give our listeners an idea of some of the areas that this mismatch becomes apparent?
Yeah. So one of the biggest things is that private equity firms are more likely in dermatology to have a higher patient volume compared to firms that are not owned by patient or by private equity. So in particular, it's a 15% more increase that one study found that dermatologists see 15% more patients per quarter compared to their counterparts who are not in private equity owned practices. A second prong of this would be it's harder for patients to get in to see a dermatologist physician in organizations that are partnered with or owned by private equity groups. So it's actually 17% higher that a patient would see what we call a mid-level provider, a physician assistant or a nurse practitioner for their first appointment compared with practices that are not owned by private equity. So pretty substantial difference there. And then the last part of this is that there's a higher emphasis on cosmetic procedures, particularly here in the US as well. So we have an industry called the medical spa business, and typically those are smaller individual practices that may or may not have been converted from more medical-based dermatologic needs to shifting to more cosmetic-based dermatological needs. It skyrocketed in the last decade. So from 2010 to 2025, we've jumped from 1,600 nationwide to over 11,500 nationwide. It's hard to find a lot of data on this to objectively quantify it, but anecdotally, it seems like there seems to be a shift, and these dermatologists who own these small practices who then partner with these private equity firms, and then they're shifted and encouraged to go more towards the cosmetic model for medical practice, especially because that generates a lot more profit because it's not typically covered by insurance.
Yeah, no, I can imagine. Well, the medical spa is not a term that has migrated across the Atlantic yet, but I can imagine that it's a highly lucrative business. So I suppose what you're saying is that some pressures are brought to bear upon the physicians to increase their throughput. Would that be fair to say that the managers are sort of placing expectations and demands on the clinicians who are delivering the service?
Yeah, absolutely. I definitely think that can be the case. Not in every single instance, but definitely has been seen.
Yeah. And I mean, what kind of steps can be taken to protect against these changes? Because what you've outlined to me sounds like it would ultimately potentially be detrimental to patient care. So perhaps shorter consultation times, seeing a less experienced clinician, perhaps less expertise in complex medical dermatology. What kind of things have physicians tried to do to mitigate or buffer against these negative changes?
Yeah, so that's another really good point. So in the United States, it comes down to the legislative level to try to prevent this and really make sure that the standard of medical care is upheld, especially in dermatology. So we have something called the CPOM doctrine, which is the Corporate Practice of Medicine doctrine. And it was created exactly for the purpose that we were just talking about. Prevents corporations from practicing medicine or employing physicians that can render medical services. But there's a gray area when it comes to the CPOM doctrine. So it's not universal in the United States. 17 of our states actually have no CPOM laws. 12 of our states have laws that make exceptions for all nonprofits. And then 11 states have laws that make exceptions for specific types of nonprofits. And the list goes on and on. So it's really all in the details here. But to answer your question most directly, it comes down to the legislative side of things. And another example of this is just last year, we had an act introduced in our government called the Health Over Wealth Act. And that was basically introduced to try to get more transparency when it comes to private equity and also medical intertwinement. And so the goal of that is to make sure that the records are available for oversight and to make sure that the best interest of both the doctors and the patients are still kept in the most priority.
And so is that in effect across all states? Is that a sort of a pan-state legislation, or is it again done at state level, that piece of legislation you've just referred to?
I believe the Health Over Wealth Act would be a nationwide
thing. Yeah. So, I mean, my next question was really going to be, in Europe, we have really yet to experience this model to any great extent. And my question was really going to be, what advice or messages would you have for, you're speaking here to a clinical population, but it's what advice would you have? And it sounds very much like, lobbying for appropriate legislation will be an important part of that process.
Yeah, so I think first and foremost, it's important for the listeners to realize that the European model of healthcare is really vastly different than the American model of healthcare. So whereas we do not have nationalized or socialized medical conglomerates here. From what I've understood, it seems like the majority of European nations do tend to have a nationalized or a socialized healthcare service. And it seems like that setup inherently would eliminate a lot of the profit potential and make it a much less lucrative model in terms of here in the United States. So I would say that's the first thing, and really just being aware of that and advocating to try to keep it that way could prevent a lot of these harms from potentially being introduced in the future. But I think you're right. It's not completely preventative. There has been some instances of private equity making its way into different countries in Europe. Specifically in Germany, it's already made its way there. But I think we really need to advocate as physicians as well to make sure that we have the data to make objective conclusions and make sure that we truly know all the facts before we make drastic changes or lobby for a different legislative position.
Mm-hmm. And I think that's partly why I felt your publication was so important. And, many of our listeners will know that the EADV, which is the European sort of umbrella group for dermatologists here, we do have quite a strong advocacy group. It would be important for us to be aware of this and bear that in mind in our visits and lobbying activity at the European Parliament level. And again, in researching this topic a little bit more to prepare to speak to you today, I came across a white paper written by the American Antitrust Institute. And, it was a long and very well written document making many of the points that you've raised today. But it stated in its opening, which I thought was quite striking, that it felt that the private equity model was fundamentally incompatible with the provision of good healthcare, which is quite a sort of sweeping statement. Is that one that you can agree with, or do you think it should be a bit more nuanced?
So I think it's a really good read, and particularly I enjoyed reading the case studies in that report as well. I think they shed some really nice light on the intersection between medicine, business, and in particular private equity. But I don't think I would go as far to say that it's fundamentally incompatible with the provision of good healthcare. I think that it definitely does offer some advantages, and if a patient was able to get into a new branch of a medical office that just opened because of that influx in capital from a private equity firm, and they were diagnosed and treated for a healthcare condition, I don't think that I would necessarily agree with that statement. I think I would take a step back and I would say that we need fundamental oversight and responsible leadership to ensure that we're ensuring the best for both physicians and also the patients that they care for.
Mm-hmm. I think you've hit on something really important there. I mean, we all know that the practice of medicine, particularly as we progress, inherently involves more and more leadership, be it leadership of nursing colleagues or leadership of our resident colleagues. And I suppose trying to integrate medics into the management structure of these private equity acquired firms. Do you think that's something that could help to protect against the sort of more nefarious consequences?
Absolutely. I think you raise a really good point, and I completely agree.
And so it would help us because, we've acknowledged that there are lots of potential benefits in terms of expansion, updating equipment, and I guess my concern would be that for every one of Max Oscherwitz, who's interested in both business and medicine, there would be very, very few doctors, I think, who have the kind of capacity and the interest, let's say, in the business world, the entrepreneurial world. But maybe we need to be cultivating that a little bit more in our perhaps even in our undergraduates.
Yeah, and I think it really comes down to making sure that we advocate for financial literacy amongst our new physicians as well. So encouraging prospective and new doctors to go out there and really try to become familiar and familiarize themselves with not only the basic concepts, but how that applies to daily practice and how it can be implemented into medicine on a daily basis as well is really important.
Yeah, and could, I imagine, be very, very fulfilling. Well, but before we sign off, I just wanted to ask you one other thing, Max. You mentioned their perspective, and just going back to your experience as a Fulbright scholar, you mentioned that you were in the context of the Colombian Red Cross, you were setting up some sort of temporary medical clinics. Can you perhaps tell our listeners a little bit about what that was like and what lessons you learned there that you've brought to your medical practice today?
Absolutely. So this was in 2019 to 2020, right before COVID spread to the Americas, actually, is when I came back from this experience. And my Fulbright award was really multifaceted. So it was partly teaching scientific courses to university professors. So I worked with individuals who were PhDs primarily. And they wanted to teach their own classes to their university students in English to try to really make sure that the students had a strong understanding, and so they could go on and author publications themselves. And so we had things like public speaking courses, scientific writing courses, professional networking courses, and conversation clubs. So that was one tier of my Fulbright award. Then the other part was I actually worked with the Red Cross, and I was situated in eastern Colombia, which is quite close to the border with Venezuela. And I'm sure most of you know that there's still an ongoing crisis in Venezuela, a socioeconomic one, and individuals were actually leaving the country to try to seek out better opportunities elsewhere. And we met some who went all the way to North America and all the way to the tip of South America. But the common thing is that they would pass through my department in Colombia, where I was living at the time, called Santander. And so we would go out into different parts of the department, and we would bring a van and medical supplies. We had an internist, a dentist, a psychologist, and a few nurses. And we would actually go out to where these migrants were sleeping and walking, and set up sometimes on the road or wherever we could find a space, a clinic for them to come and get medical care. And we saw everything from basic rashes to really complex management of infectious diseases like leishmania. But it was really a fulfilling experience, and we didn't have a lot of resources. So I think it made me a much more avid thinker, and really made me rely more on the history and physical examination. So that's something that I still try to keep with me today. And ultimately, it improved my fluency in Spanish as well. So I think it was a very meaningful year, and something that's near and dear to me today.
Well, I'm sure it's made you a much more resourceful doctor than you might otherwise have been. And, really fantastic. Congratulations on that. Huge achievement, and a world away from private equity. So with that, I will thank you very much for joining us, Max Oscherwitz. And I found our conversation really interesting, as I'm sure our listeners will. And I hope you'll join us next time on the EADV podcast. Thank you.
Thank you for listening. And if you haven't already, please make sure you subscribe on Apple Podcasts, follow us on Spotify, or otherwise you can find us on any major podcast provider. We appreciate you joining us and look forward to presenting more interviews on other important topics. Until the next episode, take care of your skin.